Okay, I warned the students that we were going to be joined by a few faculty members, and so you see we have a little bit larger room than we had before, so thank you everyone for coming to the second part of the Urban Health Seminar this morning. I am John Stewart, faculty member in the School of Public Health and program manager for the Partnership for Urban Health Research. We thought we would try something just a little bit different to begin the Urban Health Seminar for the fall semester and have a panel discussion of it from three very seasoned members of the Partnership for Urban Health Research. They've been involved really from the very beginning of the partnership and helped bring the Urban Health Initiative to Georgia State and make the emphasis on urban health what it is today. And so the participants will be Charity Scott, who's a professor in the College of Law, Erin Ruel, who's a professor in the Department of Sociology, and Volkan Topalli, who's a professor in the Department of Criminal Justice. I'm going to give just a brief setting of the stage here, and then each of the three of them will have a brief presentation, and then hopefully we'll have a robust discussion to get your views and questions about what is urban health and what does it mean to Georgia State. Okay? So tell me, how does this show up in the back row there? Professor Gaiman, you see?
Purple doesn't show up well.
Okay. All right. Well, let me just walk you through this and tell you what you're looking at very briefly. This is a framework that was suggested by three leading urban health researchers: Nicholas Freudenberg, who's at Hunter College at New York University; Sandro Galea, who's a professor at Columbia Mailman School of Public Health; and David Vlahoff, who's now the Dean of Nursing at the University of California, San Francisco. And they've long been kind of the leaders in kind of framing the field of urban health for us. And they've published this framework in some of their textbooks. I've adapted it slightly, but they deserve the credit for setting up this framework that shows basically that there are multiple layers of factors related to people's health that can be put into a framework of examining urban health. And the part maybe that you have the most trouble with is along the bottom here. It shows that kind of across all of these issues, there are big enduring structures in our world, like our geography, our cultures, our religion, our government structures, our economic systems. So there's things that do change over time, but change very slowly and are probably a little further removed from our health, but nonetheless play a huge role in influencing the health of all people on Earth. Okay? The next area that they organize is major global and national trends, and those are things like immigration, the changing character of cities to develop suburbs, the role of government changes over time, and there's a move toward globalization as an example. Next, they believe that there's a set of municipal level determinants, and those are things like the policies that governments put in place in cities, the markets that cities bring. Here in Atlanta, for example, we have our own system of markets for food, for housing, for labor, for other goods, and those all have some effect on people's health. And then we have civil society. Those are the organizations that comprise our cities outside of the government context, and movements that we have within cities that shape, that are based on trends, based on people's views, and collectively make changes in our cities. Next, we have a set of urban living conditions, and the things that they identify as the most important are, first of all, the characteristics of the population itself, the demographic factors, the ethnicity, people's attitudes, how people behave. Second of all, we have the physical environment. That's all of the built aspects of our environment around us, things like housing, our transportation systems, the pollution that results from these systems, the systems that we have to remove pollution and waste from our cities. Then we have social environments. That consists of social networks. In other words, your network of friends, your family, your connections to your community. It also includes how the capacity for those social systems to operate effectively. Can they do the things that you intend for them to do? And we also have health and social services. We have a system of health care specific to the community, and we also have social services that are providing services to the population to one degree or another. Finally, as a result of all of those sets of factors, we have outcomes. And in urban health, we're concerned with health outcomes and non-health outcomes. Example of a health outcome is the prevalence of HIV in African American men, for example. An example of a non-health outcome, and you might be surprised, well, why would we be concerned with non-health outcomes if we're concerned with urban health? Well, some of the things that you are concerned with, it's difficult to measure the outcomes, and so you want to look at the risk factors involved. So an example might be the percentage of homes in the Atlanta area that are known to have lead-based paint present. Okay. It could be pollution in the air, pollution in the water, in other words. Okay. So in the Partnership for Urban Health Research, we've tried to generally observe this framework and to develop our activities around this framework and consider the multiple layers of factors that are involved in influencing the health of people in cities. Lastly, we have public health activities that are intentional, things that we do in the public health system to try to make a difference in people's lives. Okay. This includes research into identifying and better understanding the factors involved in urban health, interventions like changing people's behavior, changing the physical environment, changing policies that affect health. And of course, the research that's necessary to find out what those factors are and whether they make a difference. So this is just kind of a long list of some of the examples of urban health concerns that we have. It's not an exhaustive list. Any of you could think of examples that should be up here that aren't, but this gives you an example of some of the topics that are considered frequently in urban health. And I think our speakers are going to highlight just a few of these. The last idea that I wanted to share with you is the idea of disciplinarity. Okay. We've come here to this place as a diverse set of disciplines, okay? You have your own specific backgrounds. And you've agreed to come here in the goal of experiencing the Urban Health Seminar. Okay? So we have a multidisciplinary group. If we were to go beyond that, we could try to integrate what you bring from your disciplines and develop new theories and new goals around urban health. We could agree to work on a research project to work toward answering research questions or trying to do some sort of project out in the community by combining all of our disciplines into a joint effort. And then finally, if we matured in those efforts, then we might want to go on to a transdisciplinary basis of forming a new discipline of urban health with its own distinct values and its own distinct goals. So I think this is the direction we're heading in urban health, and in my opinion, we're not quite at that stage yet. But ultimately, I think people would like to see urban health established as its own distinct field. So you wouldn't just talk about urban public health, you would talk about urban health that has a unique set of values into its own. And my final slide is just to remind you why we're here, because of the Partnership for Urban Health Research at Georgia State that tries to work on this multidisciplinary and interdisciplinary approach to addressing urban health problems. We have a total of about 76 faculty across the university in all of the colleges who have agreed to affiliate and work on problems that are of interest here, particularly in the Atlanta area. And I think that all of you know that we have our own webpage. The URL did change slightly just recently to urban.publichealth.gsu.edu. Okay, so I'm going to stop at this point. I'm going to turn it over to Erin Ruel from the Department of Sociology to give the perspective from sociology. The right button advances.
Hi, everybody. So I feel a little odd giving the sociology perspective on all of this because sociology is such a diverse field. So I'm going to be a little more personal about what I'm going to talk about it. But just to give you kind of a brief introduction to what is sociology, we're the study of society, social change, interactions, behaviors at the social level, and kind of the structures that limit people, what I think public health might call barriers. This tends to be what we study, and we study a broad range of topics, not just health, but social class, stratification, social mobility, crime, law, religion, you name it, we have our fingers in that pie somewhere. And sociology is also highly theoretical, and we really use theory to kind of highlight the different things that we do, which means sociology articles are much longer than public health articles. When I try to publish in public health journals, I can never make that 3,500 word limit. I'm so used to the theory that I have to write for sociology. So it's highly theoretical, but I think it's very beneficial, and it's what helps us, I think, to be interdisciplinary. And sociology is really open to methodology, meaning that if there's a method out there that some discipline uses, we steal it and use it ourselves. We're really happy to co-opt any methodology out there. And this makes us a very versatile discipline. So I mentioned some of the theories. So here are some of the theories that I like to use on a regular basis as I start my research processes. And unlike the hard sciences, there's no such thing as a paradigm shift. All these theories or perspectives stick around for a long time. So structural functionalism. This is kind of how we examine parts of society focus, like the function of them. It's more ecological. Ecological theory is kind of the same way. How is the status quo maintained? How does the system, all its parts, work to keep it running smoothly? And what happens when dysfunction enters into the model? I like to think of it as the study of stability. So the more things change, the more public health interventions we make to reduce health disparities, why, in fact, our health disparities continue to maintain and remain, and they don't really change very well. So using a structural functionalist perspective, I can kind of say, so what are the things I need to look at to see what's not changing, or what is changing at the same rate so that health disparities are not decreasing. So it kind of helps me to choose the questions to answer. Conflict theory is kind of in revolt of structural functionalism. This is a theory that says the society is the way it is because different groups have different levels of power, and they're battling over access to resources and that power. And so that's how society is the way it is. So under a conflict theory, I might suggest looking at power and how power has created the urban environment to create health disparities in urban areas. Social constructionism says Nothing's natural. Everything is socially constructed. You can tell I'm not a biologist. And therefore, I can look at something that exists and say, okay, let's break this down and let's see what are the component parts. How can I understand what's happening and get at how it was constructed to determine how we might be able to intervene. So these are the kind of the three ways I tackle any topic to come up with a variety of questions and ideas and ways to look at any phenomenon that I want to study. That's really different looking, isn't it? So in terms of methodologies and sociology, so I'm not so much urban health yet. I will get there, I promise you. I'm a quantitative person. I like to do surveys, use large data sets, but sociology is always also interested in qualitative research. This is your more social constructionist theories involved, where you're talking to people and understanding the world through their eyes, their words, their meanings. We also get involved in variable-based versus case-based, which opens up a lot of opportunities for us. So case-based might be in a particular setting. So we've been doing research in public housing. So really our study was a case of Atlanta. What does that mean? It means that, like public health, we are moving towards a community participatory model of doing research where we engage with people and understand what they need from us, and not just sort of an ivory tower research pattern where we're out there saying, no, this is what you need, this is what we're going to study, and you're just our subject. So we really have opened up a lot of research potentials in sociology. Okay, so in terms of urban health concerns, sociology has for many years, decades, centuries, focused on the social determinants side of health. And we do it really well. Our current US urban patterns are really well understood. And I would say there's two sort of main theoretical groups that I focus on. And one comes from William Julius Wilson, who wrote a book called The Truly Disadvantaged a long time ago, and has had a really odd impact on the world. But, I got to move this thing, don't I? So in terms of vulnerable populations, poverty, social class, access to services, built environment, housing, social networks, income inequality, urban sprawl, environmental justice, and violence. What Wilson had to say is that we developed an urban underclass in our society because of a lot of things that happened at the macro level. So policy changes such as urban renewal wiped out whole African American communities, replaced them, some with public housing, some with like convention centers, parking lots, and basically moved people out of the city. We also had laws like the civil rights laws in the 1960s, and equal opportunity. We had the elimination of redlining, and Fannie Mae, Freddie Mac were not supposed to discriminate anymore in giving loans based on race. And so these things were opening up society to African Americans, but not all African Americans could take advantage. But you have a 20-year period where those who could moved out perhaps of the inner cities. You have economic changes, a change from an industrial society to an information society. So a lot of manufacturing jobs left. You had white flight from the city into the suburbs. So all of these things are happening probably from World War II on to the 1980s, changing the way our society looks. You have highways being built and actually isolating these urban inner city areas. So what happens is you have very few urban or people left. They're very poor, they're very African American, living in these urban inner cities. And it's not their fault that they're there. It's a whole confluence of all of this stuff. Massey and Denton wrote a book called American Apartheid, where they focus on this idea of segregation, and they say none of these processes and policies would have had nearly the negative impact that they had if we didn't have racial residential segregation. So racial residential segregation, they say, is the kind of the key driving force for why that urban poverty group is black and not a mix of all poor people. It's the segregation. So sociology, in terms of my research, has a lot to offer in terms of kind of explaining and understanding all of these things. Am I running out of time? So that's kind of the research I focus on personally, is how does the urban situation impact health? But we can also think of sociology as a good contributor to urban health because of our understanding of urban processes, because of our understanding of social class, stratification, wealth, poverty. We're also very involved in the more ascribed characteristics, race, gender, LGBT, sexuality, age, aging processes. And because of our theoretical broadness, we're able to answer almost any research question that's out there. And why else are we a good collaborator? Why do you want us on your team? While we don't have that biological background, so, or maybe this is why we need you on our team. And I have heard somewhere that 50% of most of health is really explained by your genetics. Well, to me, that says 50% is explained by your environment then, in some way. So we do play a role in the understanding of health. And understanding this biology-environmental connection, interaction, is something that we are definitely interested in exploring. All right, I think that's all I have for you. What do I do? Who's next?
Mine is? Yep.
Clicker, microphone. And we have lots of classes at the graduate level. If you're interested in these urban processes, you should come check us out. Right now we've got a class on medicalization that's being taught, and right now we have a class on HIV that's being taught. So we do have...
You just hired somebody, didn't you, that's the medical assistant?
Yeah, well, he's coming in January. But so we've got classes, you should check us out, see if you're interested, and see if you like a sociology perspective on health or urban issues.
So, can I ask a question?
Yeah.
So in the HIV class, what sort of objectives are there? If I take that, what will I come away with?
Right. It'll be very little biology. It's going to be more about
Left and right arrows, and then
historical
laser pointer.
processes, the political reactions, the grassroots movements. So it's definitely more about how HIV affected society.
Oh, okay. And then what's the laser pointer? Where's that? That's the middle button? Yeah.
As after the change, for example, life expectancies, things like that.
Okay, our next presenter is Dr. Topalli.
Is this thing on? Oh, okay. Hi, I'm Dr. Topalli. I'm in the Department of Criminal Justice and Criminology in the Andrew Young School of Policy Studies. I'm also the chair of the Partnership for Urban Health Research. And that in and of itself should tell you something, that somebody from criminology is chairing Partnership for Urban Health Research. So the partnership is a very broad and inviting and inclusive organization, and we're looking to broaden it as much as we possibly can. We've got sociologists and criminologists and public health people and law people all participating. So I'll talk a little bit about what criminology is about and how it's connected to the public health agenda, and sort of how I see that there's like a two-way street. And I'm going to use some concrete examples from some research that I've done. Originally, my career started as an experimental social psychologist. So I did lots of experiments in laboratories with people with two-way mirrors and things like that, and then moved on to do a postdoc in criminology at the University of Missouri St. Louis, doing something completely different, which was ethnographic, qualitative-based work, as Dr. Ruel was mentioning. So I actually, in St. Louis and here in Atlanta and a little bit in New Orleans, spend most of my time interviewing hardcore street offenders. So these are carjackers and drug dealers and robbers and people like that. And I specialize in a particular type of this ethnographic work where I'm interviewing people who are active. So I don't do my interviews in prisons or jails. I go out on the street and talk to people there. I have recruiters that work for me, and I've been doing this for I don't dress like this, but I go out there and I do that kind of work. I've been doing it about 13 or 14 years or so. And I work in a lot of the neighborhoods where we as a university, but the partnership in particular, has a lot of work. Dr. Ruel has done an amazing study with her colleagues on the removal of public housing in Atlanta in some areas where actually I've done a lot of my research-based work, and at some point we're going to have to get together and write a paper about that. But I also have done a lot of interviews in South Atlanta, and so I study mostly violence and retaliatory behavior among these offenders. Okay, so that's a little bit about me. Okay, so criminology is an interdisciplinary field of study. It's not a discipline. It's a field of study. Sociology is a discipline. It has a certain outlook on the world. It has methods that are associated with it. Sociology is great because it's very broad in terms of the topics that it's interested in. Criminology is only interested in one topic, breaking the law. And so you can study that from a systems perspective, like studying criminal justice systems, or you can study it from a criminological perspective, which is understanding why offenders do what they do, that kind of thing. It's very, very interdisciplinary. So while criminology has most of its roots in sociology and psychology, it also borrows heavily from anthropology, it borrows from economics, it borrows from political science, and now from public health. And I'm going to talk a little bit about how criminology is related to public health, particularly urban crime, which is, the word urban is the key thing here for the Partnership for Urban Health Research. We're interested, and when I say we, not just the PUHR, but the university in general is interested in the problems of cities. And you'll see that in the university's strategic plan. Everyone thinks the strategic plan is just for like these mucky mucks up at the top of the university, but it's actually for the students and for the researchers and all those folks, because it's the thing that's supposed to kind of be a driving force for us. We're trying to understand and solve the problems of big cities. Atlanta's a wonderful place to do that because we have lots of problems. So I'm going to talk about two different kinds of things. I'm going to borrow a little bit from some of the research that I've done. Micro-level connections, and I'm going to talk, when I'm talking about that, I'm talking about sort of individuals and their health and how crime sort of intersects with that. A lot of people kind of look at it and say, well, what's crime have to do with public health? And if you spend any time at the CDC in the Division of Violence Prevention, you'll find that they think crime has got a lot to do with public health, particularly violent crime, but also drug abuse and drug markets and things like that. So I'm going to talk just a little bit. I'm going to give you an example of how you can talk about crime and public health at the same time at the individual level. And then we'll talk a little bit about macro level connections. And this is how I think that criminologists can borrow ideas from public health folks to advance their own research and in turn inform the public health kind of debate and discussion. Okay, so I'm going to show you an example. I do all these interviews, right? I go out on the street and I talk to these guys, gang members and all that. But a few years ago, I was on a project called Accountable Communities Healthy Together, which was a community-based participatory research project that was funded by the National Institute of Health. And we focused a lot of our efforts on a particular area of the city called NPUV. The city is, you may not know this, but divided up into these neighborhood planning units. There's 26 of them, all with a letter of the alphabet. And each NPU is comprised of like 2 to 5 neighborhoods. So there's like NPU-L, for example, is English Avenue and Vine City. Some of you may have heard of those neighborhoods. They're a little west of here near the Georgia Dome. NPUV is south of the city. It's near Turner Field. It's made up of 5 different communities. There's Adair Park, Peoplestown, Mechanicsville, Pittsburgh, and did I miss one? Mechanicsville? Did I say that one already? Summerhill, sorry. I always forget Summerhill. So, you know, we went in there, do all kinds of research projects, and I ended up doing interviews not just with the offenders, but I also did some interviews with community members, which I thought at the time was going to be kind of boring because it's like, well, they don't have anything to say about crime. There's nothing exciting there. Actually, I was way off. I was totally wrong about that. They actually have very important things to say about crime. I was just kind of stuck in my own little world. And so this is a piece of a conversation that I had with a woman by the name of Lily, who is from Summerhill and has lived there for almost all of her life. She was, at the time of this interview, I think she was 86 or 87 or so, and she'd lived there in that neighborhood for the entire 86 years, and she'd lived in the same house for 70 years, which I found to be kind of shocking. And I had seen her on a semi-regular basis because we were doing a project at Southside Medical Center called Everybody Deserves to Work. And you know, she was kind of volunteering and helping out with it. It was a reentry program. And on this particular day, I asked her a question. I said, "Are you doing well today?" And you can see the interaction between the two of us here. She was sitting down in front of me, and she did not look good, which is why I was asking her the question during the interview. Are you doing well today? No, not really. You look a little under the weather. What's up, dear? She says, missed my dialysis. I said, what? Why? Did you forget? No, I didn't want to go. I didn't want to go. Why not? You need it. You have diabetes. She wrote, I don't like to go because of them boys on the corner. And on the corner, like she says, you know the ones I'm talking about. And I said, I don't understand what that means. She said, huh. I said, huh. They're selling dope by my house. I can't get to the MARTA. Okay, so there's a MARTA bus stop that she needs to get to. I said, I don't get it, and I did not get it at the time. I can't get to the MARTA, I can't get to dialysis. Them boys get into it every day with each other, shooting and fighting. I'd rather die at home with no dialysis than get shot by a no-good thug. Okay, so at the time, I just thought of this as kind of a sad story, but there's a public health connection here. Who can tell me what the public health connection is? She's not getting her dialysis, but why isn't she getting her dialysis? It's not because the dialysis is not there, or it's kind of functionally not there, right? Why is she not getting her dialysis? It's because of crime, criminality. It's because of this criminal behavior, okay? She does not want to, she's happier staying home. And you know what missing dialysis is, if any of you are medical professionals. It is not easy to miss your dialysis. You do not look well if you miss your dialysis, if anyone has a family member that goes for that regularly. So for her to be willing to forego that because she's so afraid of what these guys on the corner are up to, and she doesn't feel like she can get to where she needs to be, that is a public health consequence of crime on the streets. And most people think of crime on the streets as having public health consequences that are sort of obvious and proximal. Like you get shot, you go to the hospital, that's blunt trauma, that's a public health issue. Yes, that is a public health issue, the direct violence, but this is a kind of a sort of a secondary effect, which actually has huge implications for society, right? She doesn't go to dialysis on a regular basis because she's worried about them boys. Then what happens? What's the next thing that happens to her?
Goes to the hospital.
She ends up going to the hospital, and where does she probably end up at the hospital? In the ICU, the emergency room. So there's all these costs associated with that, right? It's way cheaper for society if she just goes to her dialysis treatment and doesn't skip it, okay? So there are these larger costs that are involved in here. If she was somebody who worked on a regular basis, which lots of people who go to dialysis do, she would be missing work. I've done some research projects in English Avenue. There used to be a middle school called Kennedy. And there were some parents that I would talk to who kids were getting in trouble for not going to school, not because they were skipping school, but for this very same reason. There had been a gang shootout or a fight or something like that had happened on the corner, and mom decided to keep her kid at home instead of send him to school because she didn't want him to get hit by a stray bullet. Well, what's the consequence of that? He's missing out on his education, right? He's less likely to succeed. And it's not because he doesn't want to go, and it's not because the school's not available to him. It's because this crime is having this sort of secondary, very powerful but secondary effect, okay? Do I have enough time to finish up? How much time? A couple more minutes, okay. So now I'm going to switch gears and talk a little bit about how criminologists can steal from the public health community. And one question that we've had for a long time is, why is it that in these neighborhoods where I do my research, we find that violence spreads from one place to another? This is kind of a commonly known thing, that violence spreads like a disease, okay? But no one ever referred to it that way. They always just said, it just spreads. It's a spillover effect. And it wasn't until about, I think 15 years ago, 20 years ago, a criminologist by the name of John Hagen was speaking to the New York City Association of Medical Professionals, and he's the first one that sort of said, we should think about violence as a disease that spreads. And the mechanism of that spread is retaliation between offenders. So stick with me on this. I study guys who spend a lot of time out there selling drugs. They also spend a lot of time robbing people. If you're someone who likes drugs and you like money, and who do you want to rob? You want to rob drug dealers, right? Okay, and so That's true. A lot of guys go after drug dealers. Well, what are the advantages of going after a drug dealer? One of the advantages is they've got the money and the drugs that you want, right? So it's a one-stop shop. What's another advantage of robbing a drug dealer? I know it's kind of odd to think about that being advantageous, but what's an advantage of robbing a drug dealer? No cops, right? Because the drug dealer can't go to the police and say, someone stole all my crack, I would like to file a report, okay? So, so you're sort of protected from the inclusion of formal social control, the police, all right? You're protected from that. Now, what's the disadvantage of robbing a drug dealer? They're drug dealers. They're tough, they're mean, right? And they're highly motivated to retaliate against you. Okay. Now, one of the things that Erin alluded to in her talk was that there are some different subcultural belief systems on the street. And one of them is, I'll put it as simply as I can because I don't have much time, but basically eye for an eye rather than turn the other cheek. In middle-class neighborhoods, we teach our young people turn the other cheek. If somebody gets into a fight with you, someone starts something with you, you go to a teacher, you go to an adult, you never hit back, you're better than that, that kind of thing. But in these neighborhoods, it's the exact opposite. What children are taught, not just bad children from bad families, but good children from good families are taught is you stand up for yourself and you always retaliate. You have to send that message that you cannot be messed with. Well, when you get two people together, here's the model that basically starts us off, but so let me give this first. In these neighborhoods, there are predisposing background factors like lack of family structure and poverty and all those sorts of things that encourage a subset of people to participate in what we call street culture, skipping school, staying out late at night, maybe using drugs, that kind of thing. And a subset of those people then engage in the pursuit of illicit or illegal action at a much higher level. They're not just sort of smoking weed once a week or something like that, but they're doing it on an everyday basis. They're not going to school. They're not holding down a job. And when you get caught up in this here, what happens is it's a kind of a partying lifestyle that they engage in, and it leads to financial desperation because they can't hold a job because of the lifestyle that they have, right? And they need money to keep it going because you need cash to buy drugs, you need cash to hang out at the club, you need cash to buy stuff. You don't have a job, where are you going to get cash from? You engage in predatory criminal behavior. You burglarize, you rob, you steal. And that gives you cash, right? Now you have cash. What do you do with the cash? You party. What do you do when you're done partying? You're financially desperate. Then what do? You rob somebody. Then that gives you cash, right? So it goes round and around and around. Okay, well, the thing about this is that point back here, predatory criminal behavior, a lot of it occurs against other offenders that are highly motivated to retaliate against you. And that sets up this sort of dynamic, right? It's an encapsulated kind of a thing here. This is the offender who robbed another offender. This guy wants to retaliate against this offender. This offender wants to counter-retaliate against this offender. And the reason why these guys keep doing this over and over and over again is because there's a subcultural value system that says that it's important to retaliate when someone wrongs you. And there's a mainstream legal system that says if you're a drug dealer and you've been robbed, I'm not going to help you. Okay? Well, it'd be fine with most people. Most people say, well, let them kill each other. That's great. We don't have to use the legal system. The problem is, when this guy gets robbed, he doesn't always necessarily get a chance to retaliate against this person. He may want to rob somebody else, right? And so on, and so on, and so on, okay? And that's the disease state. Retaliation is the mechanism through which violence spreads. And this is a medical model. This is a disease spread model. I've showed this to public health people before, and they say, yeah, we know exactly what that is. This is patient 0, okay? And then these are all the other people that get involved thereafter. And we've done, did one series of interviews, a dice game that was robbed, street dice game on the sidewalk, got robbed by this guy, and the guy that got robbed retaliated by shooting the guy that robbed him. And that guy's family members then went to the other guy's house and shot up the house on a drive-by, except it wasn't his house. It was the house next door. And the house next door had people in it who were related to the guy who was part of the dice game. And so they got a posse together, and they went back, and they went after the other guy. And we calculated that just from that one dice game over a period of 3 years, that there were 4 homicides and 6 people shot, including a 3-year-old. Okay? So this is kind of important. Why? Because we have to think about how We stop disease. We talk about in public health primary prevention and secondary prevention. You guys are all familiar with these terms? So primary prevention would be preventing it from happening in the first place, and secondary prevention is dealing with it afterwards. Yep. Oh, you want pictures up? Yeah. So one way to do primary prevention, instead of giving someone an inoculation or something like that, is you could take cash away from the community. You could have a completely cashless economy. Because if there's no cash, then you can't buy drugs and you can't engage in illicit behavior, and there's no motivation to go after, right? That's one interesting idea. We've actually looked at this. In the state of Missouri, we looked at the transfer of subsidies to digital payment forms. Because what happened before was welfare and food stamps, you would cash them out. And so at the end of the month, there were all these people walking around with a lot of cash on the streets, and the robbers were really happy about that. And what we found is that ever since they've started digitizing payments through EBT cards and things like that, that accounts for a significant proportion of the crime drop. And that's a paper that we're going to be putting out next month, actually. And it's going to show up on Freakonomics, too. And then the second thing you do is you can have the police intervene after someone's engaged in that kind of behavior and actually take a drug dealer seriously when he says he's been robbed. That's secondary prevention. So that's kind of an example of how criminology and public health kind of can go hand in hand with each other. Just 2 examples there. Okay? I'm going to stop there because I know I'm running out of time.
Hand this over to Professor Charity Scott, the College of Law.
Oh, Charity. Oh, thanks. Okay, have lunch sometime. Talk about it.
Right, left, right, forward, back. Okay.
Okay. All right. I'm Charity Scott. I'm in the College of Law. I direct our Center for Law, Health, and Society. And remember this slide from John's introduction? And Dr. Ruel also picked up on it. These are a bunch of urban health concerns. Which ones do laws address? Excuse me, I didn't quite hear that. All of them, sure they do, yeah, you know. So in one way or another, you know, law is going to get involved in public health. What I want to do in my time is to talk about the way that we here at Georgia State, through one of our examples, one of our projects, use the law to help promote the public's health through a partnership that we have. And if you look at this, genetics aside, definitely a contributor to an individual's health. In terms of population health, this is one person's pie chart, if you will, of the contributions of the social, economic, environmental determinants of health, and that's where we get involved at every single level. All right, here's the partnership I'm going to talk about. It's called the Health Law Partnership. HELP is its acronym, and we're a partnership with the College of Law, with the Atlanta Legal Aid Society, and with 3 of our children's hospitals at around the metro area. Hugh Spalding with Grady, Eggleston and with Emory, and Scottish Rite outside the perimeter. And it's a multidisciplinary project as well as a multi-level project. We do education, we do public health services, we do research, and at the end I'm going to talk a little bit about the advocacy and legislation when we do systemic reform to address what we would call the social and economic determinants of health. And that's why we call it public health legal services. So those are the things we do. We're going to provide, and I'm going to go through each one of these to help you, to illustrate, if you will, how it is that law, lawyers, and law students working with healthcare professionals and graduate students from public health, social work, and other health-related professions can, by working with law, address some of the socioeconomic determinants of health. These are the topics I'm going to cover. You may, just as crime on the street can prevent someone from getting their dialysis treatment, so lack of transportation or lack of insurance can prevent them from getting needed access to health care. Even though, in principle, the health care is available to them, they just can't get there. What can lawyers do to help? We'll talk about that. Obviously, as we heard before, exposure to violence is a public health concern. Substandard housing, something Dr. Ruel works with a lot, impacts health. So does low educational attainment, so does not having enough food. My goal here in just a few minutes is to give you some case examples so that you can see how working with law and lawyers can address these public health, these very urban public health issues. So one is, I don't know if you all saw a few years back a movie called John Q. It's about a guy who was he was part-time employed but didn't have health insurance to cover his kids, needed cardiac surgery. And they tried to work with the hospital to get access to care, but they didn't have enough insurance, so they didn't have enough money, and then he didn't have a job. Lack of insurance was preventing the necessary health care for this child, so he took his problem in his own hands and almost had a shootout at the hospital in order to get the needed care. We don't take that dramatic approach. We, using laws and lawyers, address lack of insurance through public benefits when we can, through private health insurance when we can access it, through employment stability. A lot of let me tell you who we're serving. We're dealing with any child at Children's Healthcare of Atlanta whose family is at 200% of poverty or below. Many of our families are below the poverty line, but we'll take them up to 200% of the poverty line. And we will deal with any of those social and economic issues. We'll let the doctors address the medical issues and the social workers address the social issues. We'll address the legal issues, and having this holistic kind of approach, we think we can better improve the public's health. And so employment stability becomes a big issue for us, because if any of you have ever had children at a hospital for a chronic condition, you know you're missing a lot of work, and that causes a problem with you keeping a job. So we work on insurance issues. Here's where transportation comes in. That's why I liked your example about the drug dealers on the street, because this is a very similar case that we had. We had a young girl whose mom was taking care of her, a young woman who was on dialysis. And the problem was that mom had trouble getting all the way out to Scottish Rite on a timely basis because the Medicaid bus was always late. And so she was always late with her daughter to dialysis, which meant she was getting bumped from her schedule, which meant she was getting behind in her schedule. So what she did to try to rectify this situation was she bought a car. It was a used car from a used car dealer. And after one or two rides on that, that wasn't working either. What can lawyers do to help? That turned into a consumer fraud claim. You know, she was sold a lemon. But she needed an operating vehicle. We could get another vehicle for her so that she could get her kid to the dialysis to improve her health. It's an odd way to think about getting lawyers involved in improving a kid who needs dialysis, but that's among the many ways that law and lawyers can impact how vulnerable populations in our metro community can get access to health care. Here's another case. So Dr. Topalli talked about exposure to violence being a public health concern. We had a case, this is not a drug dealer, with this is a picture of an insulin injection. We had a family, mother and daughter, who were on the run because the mother was a victim of domestic violence with her partner. And her daughter had juvenile type 1 diabetes, and so was insulin dependent. They were coming in from another state on the run from this partner. And because they didn't have the resources, they couldn't keep the insulin cold. At the time, the insulin that she needed had to be kept refrigerated. So this poor girl was not getting adequate insulin treatment. She ended up at one of the children's hospital in a diabetic coma. What can lawyers do to help here? I mean, the medical profession can help stabilize her, right? And hopefully get her back on her feet. What we can do as lawyers is to help stabilize that family situation so that this doesn't happen again. So we can get a temporary restraining order, we can arrange for child custody, we can arrange for child support, we can get, and had they been married, you know, work on divorce proceedings, but we can work on the family stabilization while the healthcare professionals are working on the direct one-on-one healthcare services. Substandard housing, as we know, impacts health adversely a lot of different ways. Among the ways that we see most frequently are the triggers for asthma. Asthma affects kids in metro Atlanta really disproportionately hard. It's a huge admission type at our children's hospitals. A kid can go, and we've had kids, they keep going and going and going and through the emergency room because they get an acute asthma attack. And they can continue to get treated on that basis at Children's. It's open to them for the medical treatment to control acute asthma attacks. But until you address the underlying root cause of the triggers causing those asthma attacks, which in many substandard housing situations is mold, but also rodent and insect debris and that sort of stuff. What can we do? Medical folks can take care of the emergency rooms. We can take care of some of the housing conditions. We can effectuate transfers. We can negotiate with the landlords to get the apartments cleaned up. We will address the social and economic and environmental condition that a low-income family is living in. That directly impacts their health. We do a lot of education law, particularly special education law. It's well known that educational levels track employment levels, track health status. That is, the less education you have, the lower likely income level you will have, and the worse health status you will have. You'll be in poorer health. The higher your educational attainment, the higher likelihood you'll have an employment status and the higher health outcome. That's clear. There are all these wonderful documentaries showing where you live by zip code, and usually that's by employment, by income status, has a direct correlation with how long you're predicted to live. And even within the same city, a different zip code, 5 miles, 7 miles away, can account for, I don't know, 10 years off your life expectancy. All right, so education is the beginning of that. We deal with kids who have chronic illness. Keeping them in school in order that they can complete their education is a real high priority for us. So we do a lot of work with school districts around the metro area to ensure that our kids, whether they have chronic illness or disabilities that need to be addressed, get their accommodations, educational accommodations that they're entitled to under law. Food is critical to someone's health. And food insecurity, not even to say hunger, is a real problem among low-income families. What can lawyers do? Well, we can work with our community to set up food banks. We can also secure program benefits to families to ensure that these kids actually have access to the food programs available at school, as well as off-school times have access to the needed food they have that are in order to be healthy. Wanted to just mention our advocacy program. Those are the one-on-one services that we can do. Those are our public health legal services. That's how lawyers work and our law students, working with public health students and social work students as in an interdisciplinary team. But these are not just one-on-one problems. They are systemic problems. And so we've got a health legislation and advocacy course that allows students to partner with community partners, to have community partners who want to propose legislation. Our students help them prepare the bill that they want to introduce and help track it through the legislature. And we've had a number of our bills affecting the health of low-income kids, oh, actually all kids, passed by the legislature in recent years. Of course, we do research on all of this. I'm just using this as one example of how our community service and our educational programs feed into the kinds of research that we do. And I'm just one piece of a much larger center health law program, several of whose faculty are members of the Partnership for Urban Health Research. And we deal with health impact, with the impact of laws on health in a variety of different ways, not just this one in the upper corner, the health and social justice, which is the one example that I wanted to explain to you. So with that, that's all I got.
Okay. Very good. Terry, you just set the microphone down here in the middle of the table, and you said it would pick up all of this.
I think it's
Oh, okay.
not this one.
Small one.
Just this one. Okay, what questions do you come to mind do you have for any of the panelists? Don't be shy.
We're standing in way of their lunch.
When do we eat? That's the question.
Yes?
I was wondering what kind of work you guys are doing right now in terms of public housing in Atlanta and like housing justice in general, like what kind of projects you guys are working on.
Wow. Well, we're not doing much in terms of housing justice at the moment. We just completed working on a public housing study where we followed public housing residents from a year before they were relocated to 2 years or so after relocation. Our main focus, we had three kind of main focuses: housing policy, social disorganization and crime, victimization, and of course health. And where we are now is trying to publish off of all this data so that, you know, we can bring a lot more attention to what's going on in Atlanta and what's happening with these residents. So we've got in the works a paper focusing on food insecurity, a couple papers actually. We're looking at how health symptoms might change based on how you've changed neighborhoods from these very high poverty, high crime public housing units to less poverty, although more racially segregated neighborhoods that they've moved into, and so how that might affect their health. And I've got a couple of students working on mental health, focusing on mental health and how that's been changed or affected based on these relocations.
Other questions? Comments? Yes, right here.
As for each of you, how, when you do interdisciplinary work, have you all had to deal with or seen people deal with when one discipline says one way and the other discipline says do it another way?
I actually haven't had that problem. I know that's kind of, maybe that sounds like a very kumbaya kind of answer, but I've done, I work with, on this campus, sociologists, economists, public health people, psychologists, somebody in the anthropology department. So I think though, I think that can happen, But I think that it really does depend on how you approach the problem to begin with. And what I find usually is that I see a problem and I realize that I can't answer it with the skill set that I have, or I don't have the data, or I don't have the background. But it's an interesting question to me, and I usually approach someone and say, can you take on this piece of it? So it's almost from the very get-go, people kind of understand where they stand. And so I've written a bunch of interdisciplinary pieces, and what I find is that when something is, when a phenomenon is a real phenomenon, that all of the different disciplines' theoretical perspectives usually converge to the same answer. You almost never get something where it's like, well, the anthropologists say this is going to happen, and that's why it's going on, and the economists say this is why it's happening, and that's what's going on. They kind of tend to converge. You find some similarities. So I'm sorry, but I haven't had that problem. I hope I don't.
We don't have a problem. Once we get started, I think, speaking from the law end, I think there's a lot of hesitancy to include lawyers. For probably a variety of reasons. I tend to think it's because most people don't know what we can contribute. But once they recognize the value of what we can contribute, then our experience has been just like Dr. Topalli's.
Yeah, I think you hit on something. That hesitancy, and I'll say it because I'm not in the law profession, it is there, and it's very unfortunate because legal scholars have a lot to contribute on some of these things.
Everyone seems to want sociology on board. I will say that I've never had any problems interdisciplinary collaboration that I haven't also had within sociology collaborations. It's often about ego, if there is any issue, less than anything substantive. So substantively, we tend to end at the same point. And often it's more just, egos or something else, but it's not limited interdisciplinary. And language also is part of that too. Coming to the same terms, jargon terms, understanding the perspectives. So that is kind of the upfront piece, and once that's taken care of, it's very easy.
Yeah, I agree with that last part, and would say that's a lot of the reason that Partnership for Urban Health Research is so important is because we need to develop a common language and understanding of how to work together and how to communicate so that we can share each other's theories to move forward toward a collective solution. There was a question over here from, yes, ma'am.
I have a comment and a question for Charity in regards to the law and health. I do environmental health research, and before coming into academia, I worked with community-based organizations in New York City and other places. And it's really difficult in terms of dealing with some of those substandard housing issues and indoor, quality issues, because for some things that you don't have, there's no indoor air quality standards. So I know that it's notoriously difficult to have landlords to clean up things, to clean up mold, and even to clean up lead and things like that. So I just want to, to highlight that as well to, the people who are here. And I wanted to actually ask specifically about the health law program here. Does it focus specifically just on children, or if someone's having an issue that's addressing an elderly person, is that something you would address as well? Because I met someone actually yesterday I was talking to at a conference, and he's working with some elderly people who are having issues with mold and their landlords not cleaning it up.
So our project, the one that I was speaking of, is limited to children. The Health Law Partnership, and specifically to children who are patients at one of the 3 children's hospitals. The Atlanta Legal Aid Society has a senior hotline, and they do represent an elder population on a whole variety of issues. And I'd be happy to forward, their hotline number so that you can put those folks in touch. Yeah.
Question, with regard to the drug use and criminality aspect of it, what about in countries that are more liberal with their drug policy? Do we see as much people missing work because of drug abuse? Does that occur? And what about from a law standpoint? Is there less incarceration rates? Does that have an effect as well in a family structure?
I'll start and you finish. So I think there's a kind of a stereotypical kind of belief that we in the United States are draconian in how we jail and incarcerate people, and in Europe it's very kind of enlightened. And I'll say that's probably half true. We do impose extremely harsh sentences, very long sentences. We focus much more on punishment than we do on rehabilitation. But there is rehabilitation that happens here. In Europe, it is true. They don't incarcerate people as long. They focus much more on rehabilitation. I think it's not apples to apples though, because European countries have smaller populations. They have what's called a peace dividend from not investing in their military as highly as we do. So there are all kinds of other reasons why incarceration rates are lower and that sort of thing. I will say that, you know, the idea of legalizing drugs is not easy, and Cherry can speak to this more than I can, but take Switzerland, for example, in Zurich, where they had a park where they allowed people to use as much as they wanted and had clean needle sharing programs and stuff. That ended up being a disaster. So there is a legal and a policy aspect to it. It's not as simple as saying, well, if we don't incarcerate people, then we won't have these issues. Is there retaliation? Is there drug violence in Europe? Yes, there is. Is it as high as it is here? No, it's not. I think a lot of it has to do with the legal system, but I think a lot of it is also cultural. A lot of it has to do with the sheer size of the United States, our population, the way our economy works. It's a very big, kind of complex problem, and it's not easy to make the comparisons because the social services and social support network in Europe is built very differently than it is in the United States. So it's a tough question to answer, but I would say that certainly violence and retaliation are not as problematic in certain European countries as they are here in the United States.
You want to add anything to that, Cherry?
And also, I think attitudes toward gun control are different.
Yeah, that's obvious, yeah.
And we are making more steps in the direction of not incarcerating. The drug treatment courts are a relatively,
In Georgia, drug courts in Georgia are becoming, our governor likes specialty courts.
Yeah, the drug courts where
Oddly
instead of going into prison or jail for your substance abuse, which was a crime, you can get an alternative court where you stay out of jail, and in return you engage in kind of social contracting with the court itself, which is very rehabilitation focused. And that has a lower recidivism rate than ending up in prison. It's cheaper than ending up in prison. I think that's one of the reasons our governor is so enthusiastic about this, is because it's very expensive to house people in jail, but it's much cheaper if we can keep them in the community, even working, and that's what these newer drug courts are trying to do.
Stereotypically kind of liberal solution that's been seized upon by Republicans and the right because of its cost efficiency. And actually there's a prison now in Georgia called the Coastal Prison where 150 beds have been set aside. It is a prison, but that's an entire wing of the prison is a total drug rehabilitation wing. And it's not a prison style facility except for that they can't leave. But but not bad for Georgia. Not bad for Georgia.
But, our history, speaking of, what the social construct is, we have a history in this country of politicians not wanting to be soft on crime. And that was, that accounts for 3 strikes and you're out rules, mandatory prison sentences, mandatory length of prison sentences, and all of that. And the attitude is shifting.
Because the one thing that trumps punitiveness is money. And so I think that the way the governor has made the argument by, it's an easier argument to make when the economy hasn't been so good to say, hey, we really need to buckle down, and this is one area where we're spending a lot of money. It also doesn't hurt that his son is a specialty court judge. That probably helps a little bit too.
Well, we're over time. Does anyone else have a last burning question that you're going to feel awful if you don't ask before leaving? Well, I learned a lot from listening to our panelists, and I hope you'll join me in giving them a round of applause. I love your interest in criminology too, so you'll be very happy to know that next month Professor Dabney from Criminal Justice is going to be one of the presenters to talk about his role in murder investigation research. And he gives an interesting talk along with Dr. Dye, who'll be talking about his analysis of drownings in Georgia using GIS.